And then before we get started, I know y'all have a psych exam next Monday, I think. So would y'all rather like have a live like review session, or do you want me to just like record it and then post it and post the PowerPoint? Okay, and I know there's also an SNA meeting today. So do you guys want to do peds tomorrow, or do you just want me to record that one too and then just post it tomorrow? Okay, cool. So I'll record both of them and then I'll just get those posted before the end of the week. And then also just again for like recording purposes, I said catatonia was a negative symptom of schizophrenia last week, and it's a positive symptom because Hernanda said that in her slides, and then I double checked in the book and it is. So I'll definitely fix that on the review PowerPoint so there's like no confusion, and I'll just double check all my stuff in the textbook before I post it this time. Okay, so we're gonna start with dying, death, and grieving. And then here's my contact information again, if anybody needs to contact me. Oh yeah, so this one's dying, death, and grieving, and then also sleep, because I saw there was like 9 miscellaneous questions on the blueprint, so she could pull from that, and also from like exam 1 content. So I'll put like a few exam 1 content things and the PowerPoint review, but just go back over the first exams like PowerPoint, like the review that I posted. So models for end of life care. So this is dying, death, and grieving, by the way. So hospice, it supports and care for patients facing death. The life expectancy of the patient is probably less than 6 months, and then it's available to everyone regardless of age, diagnosis, or ability to pay. And then palliative care is patient and family centered. So it's caring for those with incurable chronic diseases like diabetes, heart disease, dementia, Alzheimer's, anything like that. It promotes patient autonomy and access to information and choice. And we want to try to treat patients and prevent them from suffering. So using medicines to sedate them and to reduce pain for the patient. So basically just making the patients pretty comfortable. It's the same, it's not the same for both, but like in both hospice and palliative care, you're kind of just making it comfortable. So grieving, it's a normal response, and there's no clear ending to grieving. So when a patient or a person in general is grieving, they should have decreased sadness, anger, and eventually acceptance. So for adults, it's within about a year, and then for children, it's within 6 months. So some normal signs and symptoms of grieving are excessive crying, anxiety, fatigue, insomnia, anger, change in appetite, depression, things like that. So like, when you lose like a loved one, those types of things that you start to feel and experience when you're in the grieving process. So mourning refers to things people do to cope with grief, including shared social experiences of grief. So like viewing hours, funerals, things like that. So everyone grieves, but not everyone engages in mourning. So that's a good thing to remember, because even though people are grieving, there might not be mourning. And then if changes in grief process have not occurred, that means the patient is experiencing complicated grief, which is different from regular grief. So complicated grieving, it occurs in 2 to 5% of cases. So it's persistent bereavement disorder. So for adults, it's longer than 12 months. And then for children, it's longer than 6 months. Because remember, they should start to eventually have that acceptance for adults in a year, and then for children, 6 months. So a hallmark sign and symptom is time. So like I said, if they're grieving for more than a year for adults or more than 6 months for children, and then if they can't function normally. So the outcome that we want to have for these patients are that they can experience grief resolution, so they can start to have that acceptance. So some signs and symptoms of complicated grieving are emptiness, anger, disbelief, detachment, self-blame, inability to move on, suicidal ideations, and the urge to self-harm. And then the interventions are just treatment, so talking to a psychiatrist, drug therapy, like having some type of support so they can like verbalize what they're feeling, so we can like help them get through the complicated grieving. So anticipatory grief, so their future loss is mourned in advance, so they're just like anticipating like the feeling of grieving. They're adjusting life to accommodate the time that is left, so foreseeing how the future will be altered by the loss. And then anger is a common component. So like anticipatory grief, so like people that know, like family members that know that somebody's gonna die, and like they're kind of just waiting for it to happen. So like something like that, like think of it in that scenario. And then grief is just intermittent dysphoria. So they have bouts of grief, and then humor or happiness. So their thought content, they'll have memories, and then their self-esteem will be preserved. And then their thoughts of death, meaning, so means of joining their loved one that's passing. So major depressive disorder. So they'll have constant dysphoria, and this is the difference between grief and major depressive disorder, sorry. And they'll have no bouts of humor or happiness. Their thought content will be self-derogatory, and then their thoughts of death are related to their feeling of worthlessness. So just so you can like see again, like the differences. So like with grief, they'll have intermittent dysphoria, and then major depressive, it's constant. And then grief, they'll have bouts of grief, and then humor and happiness. So they'll be sad sometimes and then happy some other times. But with major depressive disorder, they're like not happy at all. They're always just feeling like constant sadness. So it's good to know like the difference between the two so you don't get them confused. So here are like things you should say to people like when they are grieving, and things like not to say. So what you should say is like, your loss must be devastating. I can't imagine how you must be feeling right now. Or it must have been so shocking to lose your husband so suddenly. Did he have any symptoms? Your loved one was irreplaceably special. I can only imagine how much you're missing her now. You're married for 46 years or 36 years, and I would like to take the flowers from the funeral home to your house. So those are examples of good things to say, because you're not like sympathizing, you're empathizing with them, and you know, not coming off like, I can't think of the word right now, but yeah. And then things you shouldn't say is, I know how you feel, because that means you're like sympathizing with them, and like you don't want to, those are things you don't want to say to the patient. Kind of like think back to TC. So TC is a big thing in psych. At least he didn't suffer. Have you thought about getting another whatever? She's with God now. This assumes that the person believes in God and makes them feel betrayed or punished by God. You can be grateful for the time you had together. This implies that the griever is ungracious. Or let me know if there's anything I can do for you. Asking them to find something to do for you is an additional burden. So these are the kind of things you want to avoid saying to people that are going through that grief process. And then Kubler-Ross theory. So his theory suggests that we go through 5 stages of grief. So denial, anger, bargaining, depression, and then acceptance. So for the first 4 stages, they might happen in random orders. It doesn't always happen as denial, anger, bargaining, and depression. Like you can have the bargaining first and then anger, denial, and depression. It really can go either way. And then the 5th one is usually the last one, but it can also go to regret and then back to another stage. So it just depends. I'm going to go into this denial in the next slide. I copied and pasted it twice, sorry. So denial or isolation, the person or patient is in disbelief or shock about the situation. So this is like a buffer. So it's like after you receive the shocking news, it allows the patient to regroup. So a patient might do doctor shopping to make sure about their diagnosis, like if they got diagnosed with like cancer or something. So like an example of that is, there has been a mix-up with my test results, or no, it can't be true, that's impossible. So, you know, just denying like that event is happening is one of the stages of grieving. Anger. So it surfaces when the patient is ready to acknowledge the situation, but they're not happy about it and they're pessimistic. So anger is unpredictable on any person surrounding them. So the most important things the patient needs if they're experiencing anger are respect, understanding, attention, and time. So an example of this is like, why me? Why not somebody else? Or they can show their anger like physically. So that's another stage of the grieving process. And just remember, again, they don't always happen in this like particular order. Bargaining. So as the patient attempts to deal with overwhelming feelings of vulnerability and helplessness, they may secretly try to make deals with a higher power to prolong their life. So an example of this is, I'll stop smoking if I can just stay alive long enough to attend my daughter's wedding, or if only I'd gone to the doctor sooner, or, you know, just like things like asking for like more time, or like, you know, just trying to bargain with like that diagnosis. Depression. So this phase arises when the patient can no longer avoid the sense of great loss. They feel guilty because of the strain they're putting on the family, and then deep sadness for experiences that they might miss out on. So the two phases of depression are preparatory depression, so preparing themselves for separating from this world, and then reactive depression, which is an unrealistic guilt or shame about their illness. So it's imperative that the patient is allowed to express their justified sadness. This is the stage which the patient is encouraged to talk about their feelings the most. So once the patient's in this depression stage, this is when we want to encourage them to start speaking about how they feel about like their diagnosis or like their family's diagnosis or whatever. So if you see that your patient is already like in this depression stage of grieving, try to get them to talk about their emotions and get them to express that to you. And then acceptance. So the patient may not be as talkative, so time of silence may be the most meaningful. It is a final time for resting, free of pain and struggling, free of pain and struggle. So this phase can be notably difficult for loved ones of the patient, as they may not have accepted the impending loss and view the patient's ambivalence with their death as giving up. So, you know, I don't know if any of you guys have ever seen My Sister's Keeper before, but at the end, yeah, like I think she had leukemia. I'm not really sure, but she had some type of cancer, and she was like, she had already made it like through the 5 stages of grief, so she was already at acceptance. But for her like family members, it was really hard for them to like, you know, accept the fact that she didn't want to continue to go through the treatments. So that's like a kind of a good example of like this stage. Like they were trying to do all they wanted to keep her alive, but she's already accepted like that she was gonna die already. So some pharmacological treatment for grieving. So you can give them antidepressants. So SSRIs, tricyclic antidepressants, or MAOIs. So make sure you go back over those meds because those meds will pop back up on this exam. Analgesics, so morphine, fentanyl. And remember, before we give any of the analgesics like morphine or anything, you want to check the respiratory status, because remember, it's a CNS depressant. So you want to make sure that they're breathing properly before, and like their respiratory rate is in normal range. So are there any questions over dying, death, and grieving before I go to sleep and like sleep disorders? Okay, I'm gonna go on to the next. So now we're gonna talk about sleep. So the importance of sleep, so the impact on health. Sleep has an impact on your cardiovascular system, the endocrine, the immune system, and neurological functions. It also impacts your quality of life. So not getting enough sleep could be bad. Like if you don't get enough sleep, it's almost like if you're like drink a lot of alcohol, you know? Like if you try to like operate like machinery or a vehicle, like if you're sleep deprived, like it's like being like legally drunk. So some risk factors for not getting enough sleep are like obesity, hypertension, cerebrovascular diseases, mood disturbances, diabetes, anything like that. And then it also has impacts on your personal community, your personal life, your community, and your safety. So some consequences of sleep loss. So excessive sleepiness, so difficulty staying awake. So it could impact your social and work functioning and increase risk for accidents. So like I said, like if you don't get enough sleep, it's like you're driving drunk because your brain is like the same almost. So sleep restriction, so a disruption in the normal sleep cycle. Chronic sleep loss can impact health and well-being. And then sleep deprivation, so a discrepancy between hours of sleep obtained and hours of sleep required for optimal functioning. So it impacts the quality of life, health, and safety. So we want to make sure that we're emphasizing the patients like that they're getting enough sleep daily, because it really does impact your quality of living and like how you like function day to day. So some diagnostic procedures, so polysomnography. Sorry if I butchered it. It's used to diagnose sleep-related breathing disorders and nocturnal seizure disorders. So this can diagnose sleep apnea. And we're going to go over sleep apnea in a few slides. You can also do the multiple sleep latency test, or MSLT, which measures sleepiness in a sleep conductive setting. Maintenance of wakefulness test, or MWT, evaluates ability to remain awake in situation conducive to sleep. And then actigraphy is used to evaluate sleep patterns and sleep duration by recording body movement over a period of time. And like I said earlier before we got started, I don't know like if she's gonna put sleep on the exam, but I did see like the little miscellaneous like questions so she could pull from it. So I'm just going over it just in case. So insomnia is the most common sleep disorder in the US, and it's characterized by dissatisfaction with quantity of sleep. So 3 factors that may cause insomnia. So it's predisposing, precipitating, and perpetuating. So predisposing, the individual factors that create a vulnerability to insomnia. So their history of sleep quality, do they have depression? Do they have anxiety? And are they in a state of hyperarousal? So these people describe themselves as like night owls or light sleepers. Precipitating, so external events that trigger insomnia, so personal difficulties like medical, psychiatric disorders of a brief change in role or identity, so like becoming new parents or like, you know, starting a new job so you can't sleep. And then perpetuating is sleep practice that maintains a sleep compliant. So drinking lots of caffeine before a test, it'll make it hard for you to sleep later. Alcohol abuse or napping a lot during the day means you can't sleep later on at night. So narcolepsy is the uncontrollable urge to sleep. So for example, if they're driving on a highway and they fall asleep, that could be narcolepsy. Like they can't control when they fall asleep, you know, they kind of just fall asleep randomly. So people with narcolepsy aren't allowed to drive because you never know when they'll fall asleep, and that's dangerous to themselves and other people on the road. They can also have cataplexy present. So this is the bilateral loss of muscle tones while maintaining consciousness. So it's like they're frozen in place, but still know what's going on. So cataplexy can be triggered by a strong emotion like anger, frustration, laughter. And then cataplexy, the big thing you need to remember is REM sleep paralysis during wakefulness is really what it is. Some classic signs and symptoms of narcolepsy are hallucinations, so auditory, visual, or tactile. So it occurs at transition from wakefulness to sleep. And then sleep paralysis is the inability to move or speak during transition from sleep to wakefulness. It's like, you know, I don't know if anybody has ever like experienced sleep paralysis before, but it is kind of like, it's kind of scary. Like you're laying there, you want to like move, but it's like your body like physically can't, like it's crazy. And then some other signs and symptoms, so like disturbed nighttime sleep, so multiple middle of the night awakenings. And then another sign and symptom is they feel refreshed when they wake up, but they get sleepy again within a few hours. So like maybe like 2 or 3 hours later. So the treatment for narcolepsy is naps, exercise, and eating a balanced diet. You can also use sodium oxybate, which is used for treating the cataplexy symptom. So that bilateral loss of muscle tones while maintaining consciousness. So here's that sleep apnea stuff. So sleep apnea is characterized by repeated episodes of upper airway collapse and obstruction. So not being able to sleep and breathe at the same time. So sleep apnea can be serious if it's not diagnosed because you're literally not breathing while you're sleeping. So obesity is the biggest risk factor for sleep apnea. I don't know if any of y'all have ever like seen My 600-Pound Life before, but a lot of them are on like CPAP machines because they're like so big. Like they legit can't breathe while they're like laying down flat on their back. So people with sleep apnea, they can't notice it by themselves, of course, because they're sleeping. So just people sleeping with them notice it. So like if they have a spouse and like their spouse will like become concerned because they just stop breathing while they're sleeping. So some signs and symptoms of sleep apnea are disruptive snoring, apnea episodes, and then excessive daytime sleepiness because they're not getting a good quality of sleep with struggle of getting air in during sleep. And then, like I said earlier, sleep apnea is treated with CPAP therapy. So it'll help them keep breathing while they're sleeping. So that's like the biggest thing you need to remember about sleep apnea. So they stop breathing while they're sleeping. Obesity is like the biggest risk factor for it, and it's treated with CPAP. So some questions we can ask for like a sleep assessment. So when did you begin having trouble with sleep? Describe your pre-bedtime routine. So are you on social media while in bed? Are you watching TV while in bed? Do you like do work while you're in the bed? Are you on your laptop? Describe your sleeping environment. Are you living alone or do you have kids? Is there a lot of noise at night? Is there like street lights like shining into your room? Things like that. Do you use your bedroom for other things in sleep? So like doing homework, studying, maybe somebody exercises in their bedroom. Do they work in their bedroom, you know? Do you have difficulty with falling asleep, staying asleep, or early morning awakening? So like how I was saying, like narcolepsy, they like have that daytime sleepiness, or insomnia, like they don't really sleep at all. So the difficulty with falling asleep. And then do you have episodes of sleepiness that you cannot control, which is like a good question to ask people with narcolepsy because they have that uncontrollable sleepiness and they fall asleep like unwillingly, you know? So some things we can teach for sleep, emphasize the importance of sleep and a healthy sleep routine because remember, it impacts your quality of life and living and all that stuff. You can provide relaxation techniques like meditation or like give people like yoga for relaxation. They can do sleep diaries. So what they do before bed, what time are they going to bed, what time are they waking up. Sleep hygiene. So make sure to keep the same routine, shower before bed, and then go to sleep and wake up at the same time to start creating that routine. Avoid looking at the clock. Keep their room just for sleeping and try to avoid doing other activities in there. So like homework, try to move it out to like your living room or dining room or go to like another type of environment for it. Avoid caffeine beverages before bed because they'll impact how like late you're staying up. Avoid taking a lot of naps because then you're not as sleepy at nighttime. And then no exercise before going to bed because it'll cause a hyperarousal state and then it'll just make it harder for you to sleep. And then lastly, so the treatment for sleep, so the non-pharmacological methods are like beach sounds, wave sounds, counting sheep. And then the pharmacological methods are benzos. But remember, benzos are like really addictive. So keep that in mind if a benzo is prescribed. Non-benzo receptor agents, melatonin receptor agonists, and then just melatonin. So were there any questions about sleep? Okay. I do have like some practice questions We can do them, or I can just upload them if you guys want. It's really up to y'all. Okay, so I'll upload the practice questions and I'll post the recording. And then I'll also post the review probably tomorrow or Thursday. And then I'll have the peds one done tomorrow, and I'll post the recording tomorrow. So see you guys later. Thank you. No problem.